So my name is Sofia Gouveia, and I'm a consultant endocrinologist at local unit of Coimbra. And we are a bit late, so I will introduce our next speaker, Dr. Helena Tsordi. Dr. Helena Tsordi is a senior consultant at the Department of Endocrinology of the Dresden University Medical Center, as well as a clinical investigator at the Bone Lab Dresden. She is deeply involved in research concerning osteoporosis and hypopathy, and she has published several papers reporting piloPEG teriparatide trials and real-world experience. Therefore, we are eager to learn from her experience, and without further delay, I'll hand over to Dr. Helena.
Muito obrigada pela gentil apresentação. Estou feliz de estar aqui. And now I will switch into English. These are my disclosures. Yes, so we have had, I think, ample discussion about hypoparathyroidism per se as a disease, epidemiology, diagnostics, and of course we have now reached the part of the course where we are focusing on therapy and specifically on PTH replacement therapy. And just to show, it has also been mentioned also by the audience that, of course, piloPEG teriparatide is one of the options that are in our armatorium. And, of course, there were previous therapeutical agents, teriparatide, which, as we learn also in Portugal, can be used also maybe in an off-label sense, but still used. And yeah, I want to share a few words about a previous drug called PTH184, called NATPAR, which is no longer used today. And just to say that, of course, there are some emerging therapies. I will also share a few words on these. Okay, so this has also been very elegantly covered by Neil and Maria, the recommendations for management and, of course, what we can do through conventional therapy. Now, coming to PTH therapy for hypoparathyroidism, we know, of course, that the difference with PTH therapy is that it should provide PTH levels within the physiological range, and this should be achieved for 24 hours during the day, and of course to restore the other missing hormones, so downstream calcitriol, and also promote independence from conventional therapy, and to normalize serum and urine biochemistry. Skeletal health was something which is also being touched upon, and quality of life, where you will hear a lot in the next talk by Lisbeth. This has also been touched upon, which patients should be considered for PTH therapy. Just to say that there is, of course, the guideline of our esteemed colleagues, but there were also guidelines in the past, and this had to do also more with the PTH184, and these were the guidelines from the European Society, but also from the ASBMR. And you can appreciate that more or less the indications for PTH therapy were the same. What has been maybe more elegantly worded in this guideline is when to do this differentiation between recommendation or suggestion to consider treatment with PTH, and this has to do with grading of evidence. Okay, this was mentioned also by our young colleague. This has to do with teriparatide, and these were the original studies of Karen Weiner, which used teriparatide maybe more than 20 or 25 years ago. So this first study was a crossover trial which was performed in children, and they used approved therapeutical schemes of teriparatide either once or twice daily. And as you can here appreciate, of course, the twice daily dosage could simulate normal calcium ranges much more prominently than the once daily dose. And then this was the first study using teriparatide, so what you were saying in this pump setting. And here they could also show the higher proportion of patients achieving eucalcemia, but also reducing hypercalciuria. And also, interestingly enough, also the dose of PTH or of teriparatide, which was necessary, was much lower when they used the pump infusion. So this has to do, of course, with the 24-hour profile of PTH per se. As we know, also physiological PTH, but also if you use IV bolus, PTH has a very short half time. And then you can appreciate here that teriparatide has about 12 hours half time. The RH-PTH 184, which was a NADPAR, has about 16 hours. And of course, the infusion pump, but also the transcon or long-acting preparations have much more longer half times. This is just to show the difference between teriparatide, so 134 for Theo, or the previous preparation, NADPAR, which was approved a decade ago. And there are a lot of countries, including Germany, where we had experience using this preparation. As said, it had a relatively short plasma half-life, so about 16 hours, and it was recalled in 2020 in the US, and also manufacturers discontinued its production 1.5 years ago because of some rubber particles or other production issues. And just to say that there are also more and novel emerging therapies for hypoparathyroidism. We will talk about Palopeg in great detail, but just to mention eneboparatide, which is also PTH receptor ligand in a specific form of PTH, the R0 form, meaning that this is also a long-active preparation. And as mentioned, there are oral and small molecule agonists of the PTH receptor agonists, and as mentioned also before, the antagonism from the calcium sensing receptor, which comes from the setting of ADH. So there are also more exciting stuff in the armatorium coming up. Okay, so we said one of the basic issues that we had was that we wanted to prolong half-life of the product, and how can we do this? We can either modify the protein, so this is biochemical knowledge, either with covalent binding to PEG preparations or fusing with albumin or antibody fragments, or we can use an unmodified protein and link it to this prolongation technology. This would mean that we would have a prodrug, which would then be released into circulation. And this is exactly this transcon technology of Palopeg teriparatide. So this is the molecule, the prodrug, and as you can appreciate here, it is in its inactive form, and it is bound to this transcon carrier through this ligand. And once you apply or you inject the medication, and this has to do with the pH of the body, it can be unlocked, and this carrier then gets removed. The active PTH is the one that binds to the receptor, and this ligand is then removed through renal clearance. And there are two major studies of Palopeg teriparatide. This I invite you also to come to the Ascentis Symposium on Saturday, because I will be presenting the long-term data of Path Forward, this 5-year study, and the pathway study of 3.5 years. So just to give you a small taste, this Path 3 trial designed was patients that had, for the first 26 weeks, either palopeg teriparatide or placebo, and then they had an open label extension phase. And as you can also appreciate, there were some endpoints which had to do with renal safety, which had to do with quality of life. And just addressing the point that you made before, the Path Forward phase 2 trial did have a skeletal remodeling endpoint. So this has been looked into great depth, both in the setting of BMD and TBS, and also bone turnover markers. And yeah, like I said, this is just a small glimpse into this. The major, of course, conclusions of these 2 studies was that it had sustained efficacy and also safety, and that it could achieve an independence from active vitamin D and calcium in a large number of patients, nearly 96% of patients. And what is more also of interest is this improvement in kidney function and also in quality of life, and also the skeletal endpoints, meaning that there was a more normal phenotype, if you want, from the low bone turnover that it is normally accustomed to, linked to hypopara, to a more euparathroid state. Okay, but I would like, especially for this course, now to come to some practical aspects of using palopeg teriparatide. And one question is how to switch from conventional therapy to palopeg teriparatide. This is adapted by the summary of product characteristics of Yorvipath. So the recommended dose to begin with is 18 micrograms, and you start as a step 1, simultaneously reducing, and I will show another slide on this, vitamin D and calcium supplementation. Because it has such a long half-life, of 60 hours, and this sustained release, it doesn't make sense to immediately check calcium. But you should first wait for 7 days after checking, and then monitor weekly for these dose adjustments, and of course monitoring for hypocalcemia and hypercalcemia symptoms. So this is just to show you what it looks like. There are 3 different pens, blue, orange, and red, and these have respectively also 3 different doses. So you have 6, 9, 12, 15, 18, 21, and 24, 27, and 30, and you can also do combinations between these doses. Okay, and here is the algorithm of how to go about it. So it's a bit different if the patient is still taking active vitamin D or not. So if the patient is not taking active vitamin D, just calcium, then you decrease calcium supplements by this dose. And of course, if they have less than 1,500, you discontinue it completely. What is the case if they're still taking active vitamin D? In this case, it is also a bit dependent on their calcium on the day when you do the switch. So if their calcium is higher than 8.3, you should discontinue active vitamin D. If it is less, it is propose and we can discuss about it if we do it like this, or if you want to be a bit more cautious and just reduce it by 50% and then do the controls as said. Okay. And I was very happy now to see the study of Maria, because we have done a similar study in Germany. And this was published last year. It was a study of 5 centers in Germany. And here we had the setting that we wanted to see patients that were on RH-PTH 184, and that they would be switched immediately to TransCon PTH. So we didn't have from conventional therapy to switching to Palopeg teriparatide. So here you can appreciate the different doses that these patients had before from NATPAR, 25, 50, 75, or 100. And as Maria also mentioned, the switch was done exactly the same day, the next day, and it was done with this recommended first dose of 18 micrograms. And of course, the post-switch management had to do with how their additional conventional therapy, but because some of them already or still had, even if they had NATPAR, and of course also their symptoms. And yeah, as you can appreciate, there were 40 patients, 37 post-surgical, 3 had hereditary hypo-PTH, mean age 54, and they had been nearly for 4 years before on NATPAR. And here you can see that their biochemical markers more or less were within the reference ranges. So, what we could find is that 80% required individual TransCon PTH dose adjustment in the first month, and interestingly enough, about 38% could reduce the dose, and about 43% had to increase the dose, and the others had the same dose, so 18. And now coming to something which is a bit close to Neil's question about if you can predict beforehand who is going to need maybe a higher dose or a lower dose. So this, of course, is all associations. And as you know, association is not a very, very scientifically high-powered method, but at least in our data, we saw that the patients that started with a NATPAR dose which was lower than 50, and they were switched to this 18 microgram NATPAR, had a hypercalcemia risk. So this would be the patients which we would say maybe it could be even more safe to start with an even lower dose, so with 15 micrograms. On the other hand, the ones that had higher dose of NATPAR than 75 had quite a significant risk of hypocalcemia. So this would be maybe the ones where we could even say start a bit higher with TransCon PTH. And just to say a bit about adverse events, so this is all very interesting, I think, because some of them are very difficult to discern if it is like an adverse event of the drug or if it is one of the chronic complications of the disease. I think this is always the case in such patients. But here you can see what they reported. And there were no significant differences between in the biochemistries between patients with or without symptoms. Yeah, this is the study also slightly touched upon by Maria. This is the US experience, so this is something that has been also recently published. So they had 123 patients, which were mostly on previous therapy with short-acting PTH therapy, and they were switched to palopeg-teriparatide, either from natpar or from teriparatide. And here you can see that there was no differences in patients that were switched directly or that were had first a phase of doing conventional therapy. So also, if the question is later in Portugal, when you have, of course, the possibility to prescribe palopeg-teriparatide, I think it will be also possible to do a direct switch from teriparatide. And maybe a last aspect that I would like to share with you, and this is something that we have also seen in one patient, is what happens if you discontinue. And if you discontinue, we know from teriparatide, there's a transient increase in requirements of oral calcium and also vitamin D. And the natpar studies have even also shown these hypocalcemic events in previously treated patients with natpar. And this has been hypothesized to result from a rebound event, which is similar to hungry bone syndrome. And this is when bone resorption is halted and while bone formation continues. So this is an increased calcium uptake by the skeleton. So yeah, this is something that we described with my good Italian friends. So this was a 62-year-old male patient which had post-surgical hypoparathyroidism, and he was on palopeg-teriparatide, but then he decided to stop the treatment, or he did not decide, but it was something, issues of the insurance and how they would take care of this. So in any case, it was discontinued. And what is here interesting is that in the first days after for this pause of the palopeg-teriparatide treatment, you didn't have a real drop of calcium, but you could see also 1 month after this pausing of palopeg-teriparatide that you have this significant hypocalcemia, which was managed in an outpatient clinic with increasing the doses of oral calcium and also of vitamin D, but it was such a significant hypocalcemia, which he had not experienced in the past when he was in conventional therapy. So this is something that you should be aware of. Okay, and now if we have time, I would go to the clinical cases. So this is a 52-year-old woman who has chronic post-surgical hypopara, and she has been managed for several years with calcium and active vitamin D, and she has this infamous high bilirubin and a lot of fluctuation in serum calcium and mild nephrocalcinosis. So you think that she has suboptimal biochemical control and burden of therapy, and you want to treat her with Yorvipath. And yes, so scan. So, which of the following is the most appropriate initial management when transitioning from conventional therapy to palopeg-teriparatide? Should you discontinue everything immediately upon starting? Should you gradually titrate down calcium and active vitamin D? Yes. Should you maintain everything and not change a thing? Or should you increase calcium and active vitamin D? Very good. I think we have a very attentive audience here. It is, of course, B. So, which of the following is the most appropriate monitoring strategy while having stable serum calcium on palopeg-teriparatide? Should you measure calcium annually? Should you do no monitoring whatsoever? Should you do calcium phosphate, magnesium, urine calcium, renal function? periodic renal imaging, I learned that it is a bone of contention, so you might not want to do periodic renal imaging only if she has clinical signs of nephrocalcinosis. And if she has clinical risk factors, then you would do, or factors, you do DEXA. So, also very good. It is the correct answer. And yes, so this is a 58-year-old woman with chronic post-surgical hypopara, well controlled on Palopec, teriparatide, and again, due to insurance coverage, she wants to switch back to conventional therapy. So what would you do after discontinuing? Should you delay conventional therapy for 1 week? Should you start a bisphosphonate to prevent bone loss? Should you resume doses of oral calcium and calcitriol without laboratory monitoring? Or should you initiate oral calcium and calcitriol and increase dose and closely monitor serum calcium and phosphate? Very good. It's looking good. I don't think you should delay initiation for 1 week, but as shown in the previous case, because of this risk of having a transient but significant hypocalcemia, you should even increase oral calcium and calcitriol, not forever, but for this first period, maybe of 1 month up to 6 weeks, and then to monitor and adjust therapy. So yes, I think coming now to the end, there are, I didn't show them so much, but there are ample clinical data, but also now real-world data that Palopec teriparatide is an effective treatment. And we discussed very amply who would be the ideal candidates of this, and the data support improved renal function, safety, improvement in quality of life, and the recommended starting dose is 18 micrograms subcutaneously, although, like I said, if you had patients that were previously on teriparatide or on NATPAR, you should consider adjusting these 18 micrograms. And if you discontinue Palopec teriparatide, you should closely monitor them for rebound hypocalcemia and adjust the calcium and calcitriol supplementation as needed. Muito obrigada pela vossa atenção.
Thank you very much, Dr. Elena, for sharing your expertise. And we have a few minutes for discussion. Does anyone from the audience would like to question Dr. Elena? Maybe I'll start.
Yes.
I have a question concerning the Yorvipath initiation algorithm. So when you are initiating, and if the patient is on active vitamin D,
Yes.
and has a calcium over 8.3 in the normal reference range, the recommendation is just to stop the activated vitamin D.
Yes.
But on the trials, we can see that the mean daily dose of calcitriol was somewhere around 0.6 to 0.8 daily. And we sometimes have patients on 1.5, 2 micrograms of calcitriol a day. Do you think it's safe to just stop calcitriol? Will you try a different approach?
Yes, very good question. So as I showed, if you go by this algorithm that they propose, the answer would have been to stop, but completely. But I think if you want to be a bit more cautious, maybe for the first step, and they have beforehand 2 micrograms of calcitriol, I think it could also be quite a good possibility to just reduce by 50% and then also to recheck, because you're not really going, I think, to miss a significant hypercalcemia since you will be checking in 7 days. So I think in that case you can do it like this. Yes.
Yes, please.
That was very elegant, Elena. Thank you. It's a question for you and Maria, perhaps. This morning we were talking about conventional therapy in patients when they're very physically active may require greater calcium. Do you see this in these patients? Do they ebb when they have stressful life events? Does it change
Yes.
through the menstrual cycle, etc.?
I can just say about my experience from NATPAR, the previous treatment, because one of the patients was a trainer of table tennis, which is, of course, everything having to do with tennis is very close to my heart. But still, it was someone who was also saying that because of this arduous training, and he was in a dose of 100 micrograms NADPAR, which is the highest dose, that he had these symptoms of muscle spasms and also of paresthesia. So he was taking extra calcium before this arduous exercise. So yeah, it is something that...
We also had an experience with a marathon runner who was in PTH replacement therapy with NADPAR, and he was doing two injections of 50 milligrams per day, and it was really troublesome for her during her running.
Training?
Cannot recall the word.
Yeah.
But she's now in 27 micrograms, and this is pretty much stable. I guess it's the long half-life that makes the difference. And that's why I wanted to ask you something, Elena. You were great. Thank you for the presentation. If it is, for some reason, to discontinue,
Yes.
would you consider maybe do the injection of Palopeg every other day, since it's 60 hours of half-life?
Yeah. Well, the idea then would be, what would be the setting to discontinue then in the first place?
Let's say that he cannot be reimbursed for some period, and he or she had to get back.
Yes.
So I'm not sure if it will be better in terms of rebound, but
yeah,
would you consider it?
I think that, okay, you could have the rationale of the longer half-life, and I don't think that you will see the rebound so quickly, because you also saw in these patients, you see the rebound, I think, after 3 or 4 weeks. So I don't think that they would be like at great peril of hypocalcemia symptoms. But you might, of course, also advise them also to have some extra calcium on the standby and use it appropriately as they feel with the symptoms. Yes.
Does anybody else has any question? So if not, we are running out of time. So I thank again
Thank
Dr.
you so
Elena
much.
and
Really enjoyed the course. Yes.
And quality of life, and she will shared by Professor Ana Paula Barbosa and Lisbeth. Lisbeth is coming. Yeah. Do you want to give some words? Yeah.
Okay. While we wait for Dr. Lisbeth, I just want to welcome you to this last session, and I will have some words regarding the curriculum of our speaker. Thank you. We thought you had gone, but sorry. No, so thank you for coming. I want to say that Dr. Lisbeth Winter is Associate Professor and Internist Endocrinologist at Leiden University Medical Center in Netherlands. She's a specialist in rare bone diseases and mineral disorders, calcium phosphate metabolism, and also osteoporosis. So she has not only the clinical expertise, but also very important teaching and research. And she has served in several societies like ECTS and ASBMR. So we will have a beautiful talk, I'm sure. So the floor is yours, and thank you for coming.
Thank you so much. Thank you for inviting. These are my disclosures. And I will focus on, on chronic hypopara, of course, the renal, neurological, skeletal, cardiovascular complications, the management, and the quality of life. And I understood already a lot has been touched upon, so maybe for the questions you can already answer all of them correctly. So the learning objectives would be that I would like you to understand the complications of chronic hypopara, to be able to describe their quality of life, and to know how to manage these complications and quality of life at the end of this presentation. So for the questions, maybe you can scan the QR. Yeah, can I proceed? And then the question is, and this one you probably know, which long-term complication is most strongly associated with the conventional calcium and active vitamin D therapy in chronic hypopara? Yeah, I think you understood what has been told. And then the management of the chronic hypoparathyroidism requires does it require regular renal ultrasound and brain imaging, regular renal ultrasound and brain imaging on indication, and indeed both on indication? I think this has just been explained. And the quality of life, is that affected? And does it improve with treatment? So is it lower, and does it improve with conventional and PTH replacement therapy, or only with either of them? Okay, and there is still something I can tell you. That's great. Thank you for this answer. So this is just to show you, like PTH, it is important for so many organs, and that's what already been discussed. But that is also why, of course, it affects quality of life, and it has many complications if PTH is not there. So the various complications that I will discuss now, the renal, the neurocognitive, skeletal, cardiovascular, and the quality of life. And these are very nicely described now in the guideline that was already mentioned. So the renal complications, how does it work? Well, we do have a low PTH, and therefore we do have this impaired tubular reabsorption of the calcium, together with the phosphate excretion. And this results, and that's already mentioned, in the hypercalciuria and the hyperphosphatemia. And this leads to this increased calcium phosphate product. And that will lead to the nephrocalcinosis and nephrolithiasis. And of course, that in itself can decline kidney function. And we see this also to be associated with the duration of the disease. So that can also tell you something about the causality. And this, I think I would like to emphasize, is a major driver of the morbidity of these patients. So it is really something to pay attention to and to try to prevent. And it's less pronounced, and it's also been described with, already been told, with the PTH replacement therapy logic, because then you do have the PTH back again. And then just to show you shortly, for ADH, we do have this shift of the PTH sensitivity because we have this calcium sensing receptor mutation. And this means that for the renal tubule, there is also this shift. So for a lower calcium level, there is already excretion of calcium in the urine. So this this hypercalciuria is even more pronounced in ADH, which of course is not hypopara in the strict sense, but it's of course considered part of it. And the risk of renal insufficiency increases with age in the general population, but for the hypopara patients, we see this even more pronounced. So, and this is probably also due to the fact that the duration of the disease is involved in the incline of the renal function. So then the neurocognitive symptoms, the brain fog, what is it? Well, it's the reduced ability to focus, forgetfulness, the lack of mental clarity, difficult to think clearly, confusion. And this is really bad. This affects daily life continuously. It makes you a different person. Anxiety, low mood are also very often reported. And I think, well, as a clinician, we do not always really pay attention to those complaints since we probably don't know what to do with it. But it is there, and I think it's really something to discuss. And it often persists despite the normal calcium levels. So as a doctor, you think, well, it's all well, but they still have the complaints, and it could be that this is due to the fluctuating calcium levels. And then the basal ganglia and the ectopic calcifications. Well, we all know that there is this calcification in the basal ganglia, especially in the non-surgical patients. But we don't know what the clinical importance of this is. Is it related to movement disorders, seizures, cognitive issues? We don't know. But there is a very nice study that was recently published in JBMR, well, almost more than a year ago. This is a cross-sectional study in Denmark where they compared surgical and non-surgical hypopara patients, not very high numbers, but 26 and 10, and they compared them to healthy age and gender matched controls, 25. And then they did cognitive tests, and they asked for their symptoms, and they did MRI. And in the hypopara patients, they found, compared to the controls, a reduced quality of life. They used various questionnaires that I will discuss later, but these are many general questionnaires and also a symptom diary. There was reduced cognitive functioning with a difficulty with processing speed. Executive functions, visual memory, and auditory memory were all hampered in the hypopara patients. And there was a reduced volume of the hippocampus. And I think this is the first study where this is really studied all together. And interestingly, the size of the thalamus was associated with disease duration in the post-surgical patients. And the severe brain fog patients had smaller hippocampus than those with less brain fog. So the authors conclude, and I very well agree with it, that hypoparathyroidism is associated with quantifiable cognitive deficits and it coincides with changes in brain structure that align with the patient's symptoms. And I think this is very interesting and needs to be studied further. Then the skeletal effects, well, I think that's already mentioned. So we have the low bone turnover, the increased BMD, but altered a bone quality with, of course, a reduced mineralization due to the third phase. So we have the bone resorption, the bone formation, and then we always need the mineralization to have the strong bone there. And that's, of course, the problem if there is lower calcium. The reduced remodeling capacity, so we don't really know, which was already pointed out by Neil, we don't really know the fracture risk, but we do know that microarchitecture is altered. This is because of the low PTH, obviously, and it's not corrected by conventional therapy. And then we have the cardiovascular complications, we have the arrhythmias, the torsade de pointe, and the ischemic heart disease in the non-surgical chronic hypopara patients. The surgical is not sure whether it's associated. And this is due to the chronic hypocalcemia and the calcium phosphate imbalance. So then, not all complications, of course, are as prevalent as others, and you can't predict which complications you will find in your patient. Also, cataract is quite prevalent, and then I think nephrocalcinosis and nephrolithiasis are most often seen. And some of these complications are disease and exposure time specific. So as you can, this is also from the revised guideline for the intracerebral calcifications, the stroke, cardiac arrhythmias, ischemic heart disease, and also from the proximal humerus fractures. Its risk is only documented in non-surgical hypopara. So this is really important also in your outpatient clinic to differentiate between the cause of your hypopara patient, whether you need to be aware of these symptoms and complications. And also the duration, of course, is of importance. So here you see symptoms that patients describe. I won't go over these. And they're also, of course, the patients should be educated that symptoms can be a sign of hypo or hypercalcemia. And that, well, requires, of course, different management. So that is also something to look into. And it's, I think, a beautiful table that you can just look up in the guideline. So then how to manage? Well, the laboratory investigation has been discussed. So, well, if patients are stable every 3, 6, or even 12 months, after change of medication, it should be very quickly that you check again, 1 or 2 weeks according to the guideline. PTH only once a year, only to check whether there is potential recovery. And 24-hour urine calcium only every 1 or 2 years. So that's not that often, unless, of course, you have an indication to do it more often. And then the monitoring, and that's actually what I wanted to point out with the first question. So all the other monitoring is only on indication. So the renal ultrasound only if there is a decline in the kidney function or if there are features, clinical or laboratory-wise, that make you think of nephrolithiasis or nephrocalcinosis. And the same goes for ophthalmological exam, only if there's complaints, and brain imaging only if there is neurological symptoms or atypical features. And still, we don't know what's the calcification of the basal ganglia, what it means actually. And this is, I think, the most important slide of the entire presentation, and this is the guideline. It highlights that the general goal of the management of a chronic hypopara patient is to give the patient the best quality of life possible. So they recommend treatment for the hypopara to be personalized and centered on the patient's overall well-being, with therapeutic goals that optimize quality of life, that minimize symptoms of hypocalcemia, improve long-term prognosis, and maintain calcium levels within the lower part or slightly below the reference range. And the most, what is important to realize, they say, so it is not it's not the goal to have the best values possible. The goal is to have the best quality of life possible. So don't advise on heavy dietary interventions if it's really difficult for a patient. Realize that the pill burden can be devastating. So their quality of life prevails above the absolute values, and of course the long-term complications should be taken into account there. But I think it's a different way of reasoning when you have your patient there, and it's always easy just to look at the labs and think, well, we have to change this or that. But it's about the patient, what he or she tells you. And that's now, I think, very, very nicely stated within the guideline. And so there I come to the second part of my presentation, the quality of life. So what is that, actually? Well, it is the degree to which an individual is healthy, comfortable, and able to participate or enjoy life events. So it's not only health, it is wealth, employment, the environment, physical and mental health, of course, education, recreation, leisure time, social belonging, religious beliefs, safety and security and freedom. And of course, I don't want you to touch upon all of these within the outpatient clinic, but it is within all these that the physical and mental health are embedded. So impaired quality of life in hypopara, we see that it is from musculoskeletal and neuropathic pain, from fatigue, which is a really, really important complaint, weakness, increased anxiety, increased risk of depression, and we see an increased risk of hospitalization for depression and affective disorder. So it's really important. And then we can ask, we can try to monitor, we can try to measure their quality of life with questionnaires. And there's questionnaires, just the patient-reported outcome, and I think that is for now relevant. You also have observer-reported outcomes or clinician-reported outcomes. In this, for the hypopara, the patient-reported outcome measurements are of importance. And then we have the generic instruments, and I would like to highlight the SF36, the WHO5, and the EQ5D, which are often used. The last two are very quick. I will just show them in a minute. And we have disease-specific questionnaires. And so you need to think ahead, what do I want to know from the patient, and then decide which questionnaire you want to use. So for the disease-specific instrument, we will touch upon the HPES, since that is used for the clinical trials. And here you can appreciate the SF36, which is very often reported in quality of life studies, but it's quite an extensive questionnaire, so it is a burden for a patient to fill out. So for the SF36, you ask about the limitations of their activities, their emotional health problems, social activities, and it's all on a Likert scale, so not at all slightly, moderately severe, very severe. You ask about their energy and emotions, the social activities, it's all about the past 4 weeks actually, and their energy and emotions. So it takes some time, and it's sometimes difficult for patients to answer. Then we have the EQ5D, which is quite short. It asks about mobility, self-care, usual activities, pain, anxiety and depression. And that goes also from no to extreme. So this is quite quick. And the same goes for the WHO5, which is also quite quick, whether the patient is cheerful, calm, active, fresh, and that daily life is filled with interesting stuff. So it answers, or it gives you different information, and that is something to realize when you read studies or when you question your patient. And then we have the HPES. I don't have the, since that's author protected, but that asks about symptoms and impact of the symptoms. And that is the disease-specific questionnaire. And this is a study from Heide Sikelkopf. She did a lot of studies with, with respect to quality of life in hypopara patients. She also uses the questionnaires in her outpatient clinic, which is not often done, I think. And this is a survey among 13 countries among not adequately controlled hypopara patients. And their caregivers. It was an analysis with the SF36, so this longer questionnaire. And they reported their symptoms severity as none, mild in 1/3, moderate in half of the cases, and severe in 12%. Then they had, well, moderate to very severe symptoms of physical fatigue in 3/4 of the patients reported this. So, but please note that this was not adequately controlled patients. Muscle cramps, heaviness in the limbs, impact for ability to exercise, sleep, ability to work, and family relationships. Also, the majority of the patients reported. And the greater patient symptom severity was associated also with an increased burden of the caregiver, which we can understand. But I think it's nice that we now see that indeed this is also something to ask the person sitting next to the patient when you see him or her in the outpatient clinic. And here, this is how this is shown typically for an SF36. So you see all the domains how they score, and the lower, the worse. And this is another study. It's quite old, from 2016, but I think it's nice because it asks about quality of life in patients with hypoparathyroidism on top of hypothyroidism. And there you can appreciate it was done with SF36 and WH05, 2 years after surgery, so they were already considered stable. So there was healthy controls, and then compared in white to the hypothyroidism patients, you also see that they scored quite bad on bodily pain, general health, and vitality. But this was even worse on all domains in case of hypopara. And this was not on a certain population, this was just cross-sectional. And another study where they looked for quality of life in hypopara, but also in pseudo-hypopara. It's difficult to read, but the non-surgical hypopara patients versus norm-based controls, they had a lower quality of life. So the dark blue is the norm-based, and you see that in all domains, the hypopara patients were lower. And the same goes for the pseudo-hypopara, and this was similar for males and females. And this is a review where it was shown that quality of life is reduced in patients with hypopara on standard treatment. And 87% of the studies reported statistically significant lower scores in at least one of the quality of life domains. What we don't know, is this due to the lack of PTH? Is this because of the treatment? So it needs further studies. And then I'm almost at the end. How is quality of life in PTH replacement? So we do have studies for palopecteriparatide and for RH-PTH, and I will discuss them in a bit more detail. First for RH-PTH, so the NATPAR, which unfortunately is not available anymore, but we see that NATPAR in RCT, so compared to conventional therapy scored with SF36, there was an improved physical, body pain, general health, and vitality in comparison to their baseline. And then there was another study where actually they found the same. There was also the symptom diary, what they used, and fatigue. And there was also an improvement in the quality of life and also an improvement in their fatigue in patients that were on NATPAR. Same was seen in an extension trial, so an 8-year follow-up. There was maintenance of this improvement in the quality of life. And also with an EQ 5-day in an open label study, it was shown that there was an improvement in quality of life with this type of PTH replacement in that study. So then how is that with palopecteriparatide? We do have this disease-specific questionnaire that was used that I showed a few slides before. And we do see that in comparison to placebo, there was quite quickly an improvement in these HPS, the symptoms in the physical and the cognitive domain, so complaints that they have, and also with respect to the impact of these symptoms, there was an improvement that was sustained during 26 weeks. And in the SF36, there was in one domain, there was an improvement only in physical functioning. And then the extension, it was noted that this improvement is maintained. And you can see that actually it's quite quick. You see the same pattern. So here you see the blinded palopecteriparatide. So during the study, we have this quick improvement, so within 4 weeks. And you see the same from the moment that it is open label, you see that there is this quick improvement, which is similar, and that's maintained, and that is that is seen for the for both the symptoms and the impact of the HPS, so the complaints that they have and the impact of those complaints. And the same was for this physical domain on the SF36. The same was observed. So with this, I would like to conclude. I think a lot of information. I hope you now understand, well, you already understood the complications. I hope you now, you're able to describe quality of life and know how to manage the complications and also pay some attention to the quality of life. So as a take home, I would like to say that chronic hypopara carries significant long-term complications affecting the various domains. Prevention and monitoring are critical to minimize these complications and preserve organ function, but quality of life is often impaired, and addressing those symptoms is essential and should prevail. I think so tailored patient-centered management strategies are recommended to improve patient well-being, and that's what we all want, since that's why we treat these patients, I think. Yeah, so I think we don't need to go over the questions again, and I would like to end with this.
Thank you, Dr. Lisbeth, for this nice talk. And now I would open for the audience, if you have any questions or comments that you would like to do, please. Yes, please.
Yeah.
What's your approach, how you do it in the clinic? When you see patients on a day-to-day basis, how do you assess quality of life? How do you do that?
Do you want to know how I do, or do you want to know how I would like to do?
First of all,
I think Heide is actually the example. She really takes all these questionnaires. We did a study with questionnaires actually in the hyperpara patients with the different therapies. Quite often I use, well, in general, I use pain questionnaires, and I use the EQ5D, for example, because it's very, very quick. And then for the chronic hypopara, I would use the EQ5D. But I don't do it as a standard. It's not yet integrated in our care path, and I think that is actually not good. So I think it is, it was, of course, it was not in the guideline that there is a certain questionnaire that we should all use, or that we could easily all use, and that can also build our knowledge, since I would prefer to use the same questionnaire among physicians and then be able to team up and to combine also results and see how we can improve. So yeah, there is. It's also open for discussion. I would like to ask the question back. What do you do, and what would you advise?
we can only learn from you. We can only learn from Elena and from Heide how to assess it. But the question, of course, pops up because one of the indications for Palopec is reduced quality of life. That's also in the guidelines, but we don't have a clear guidance at the moment how to do it in the clinic, how it is feasible, but we somehow have to assess it in a structured way, because otherwise we cannot really judge just is quality of life reduced. We have to do some more structured approach to this. We don't have it yet at my clinic, my fault, but we plan to do it and to introduce it, but it has to be feasible, of course, for time constraints and so on. But,
yeah, no, I fully agree, and I think it would be wise if it's just integrated and that patients get the questionnaire on forehand, so that you together can read through it. That's optimal, and then you have it for all patients. You also get the feeling about it, so you learn to read the results, and that can also help you to decide whether you need to switch treatment, of course.
Can I ask you, what do you think to have, for instance, a mental health technician that could help in this kind of approach? Or because I think my view is that many of these things are not so objective. So maybe we could have help with a mental technician, like a psychologist, that could help us with these patients. I don't know.
I think
What
it would
you
be
think,
excellent also for the patients, of course, to have extra help with that respect. I think it will be difficult since it's expensive. It's difficult to get it integrated. So I think, for example, a nurse, if he or she would help to get all the questionnaires, or secretary to get all the questionnaires done, and that you together go through it. And of course, it's subjective, but you see the differences within the patients if you use a dashboard or something. But of course, yeah, psychological support will also be of value for these patients. Yes, fully agree.
Okay, thank you. And are there more questions or comments? We are not so much time. I don't know if... well, I think that we could close the course, if you agree. Thank you again. Maybe I just wanted to say some words. First of all, I would like to thank to all of the present that were in the course. I also want to thank so much for all our speakers and their beautiful talks. And also to thank Ascendis for this sponsorship. I think this course was really, really good for all of us. And just to emphasize that we have a rare disease, but a chronic disease with 2 hormones missing, that it's very important to make a correct diagnosis. The genetic testing for etiology is very important. Then the multisystemic disease and the complications should be followed up and managed according to everything that is going that we can see in the patient. Then the treatment should be individualized and not only based on biochemistry, but we should listen to the patient and to their symptoms and their complaints. Then the management was also speak about, I learned that the importance of the calcium diet. Sometimes we just think it's pills, but here with Professor said that the calcium in diet is quite important. Vitamin D also, as we all heard. And then the clinical cases, I think, were very interesting to show how difficult these patients can be. And at last, we have now the last hormone that we had, that we did not have to our patients, and we have it now. We hope that in future our country can also use it, this Palopeg, and we have the indications. I'm not going to say all of them, of course. I think you all have heard. This is a proved hormone with efficacy, safety, and that can increase glomerular filtration rate and also improve the bone physiology, and also, as we saw in the last communication, improve the quality of life. So I think that is all, and I also thank again for all this journey. Thank you so much.